I think the three of us agree that the last 2 years at least, or maybe even just the last year, has seen a data set for the use of lenalidomide as maintenance, which is seeing maintenance as becoming an important component of the treatment of myeloma. But what I'd like to ask you both is, what do we do next to improve on this further? So perhaps you could tell us about your study adding additional agents in, Antonio.
Well, certainly one way is to improve the induction, and from this point of view the hypothesis of combine a different agent together, and this may certainly increase the response rate and eventually the outcome. The other one is to use a more intense approach in terms of maintenance. We are currently using some lenalidomide in combination with corticosteroid, but we have still to wait a little bit to see the results.
And Paul, you're very interested in phase 1 studies with novel agents with interesting mechanisms. Where do you think that's going to take you in terms of Revlimid maintenance?
Well, I think it's several. I mean, I think that there are a number of, I think you're absolutely right, Antonio, that there are high-risk patients in whom we need to do more in terms of maintenance. And our own impression has been that from both European data and some of our own data with the lenalidomide-bortezomib combination, that a combination of immunomodulation and proteasome inhibition as part of maintenance in higher-risk patients is important. I'm also very interested in the emerging role of histone deacetylase inhibitors and these epigenetic effects that they may have. And of course, we also have the monoclonal antibodies, which are complementing lenalidomide and bortezomib. So I think you're absolutely right, Gareth, that with the new agents coming through with other small molecules, such as AKT inhibitors, for example, perifosine, all of these drugs are providing us with more opportunities because, as you know, I don't like the term low-risk myeloma. I think it's a misnomer, actually. I think there's standard-risk myeloma and there's high-risk disease, and I think the bottom line is that we need to do more for both.
I'm kind of thinking that there's more. I think there's standard risk, adverse, and then there's actually a very high-risk group, which kind of stands out in everybody's practice.
I completely agree with you, and I think that we've got a lot of work to do, but the good news is that we have plenty of tools to do it with.
So I like the data so much. I kind of like the Revlimid data that I think we had to modify our trial. So we've actually modified it to include another arm. So we have a no maintenance Revlimid, then Revlimid plus vorinostat, that hopefully is going to start recruiting in the next few months, because I think that has the potential to significantly enhance the activity of Revlimid in this setting.
I think based upon our own experience with lenalidomide and vorinostat, I would agree with you entirely. I think lenalidomide and vorinostat have this tolerability profile that's remarkable, and at the same time, what we've seen in terms of activity has been compelling. I would, however, say that I think that it's important in our trials to rationally combine all the best drugs we have. And I think, this is an important point, that we already have, of course, in bortezomib, a first-in-class proteasome inhibitor, but we will be having second-generation proteasome inhibitors with proteasome inhibitors that will be oral. So I think we will then have the opportunity to further exploit those as well with the convenience of that oral route.
You're a leading light in the European Myeloma Network. How's this data going to affect your selection of trials, and how are you going to expand the trial portfolio to take this into account?
This is secret. No, it's not secret, but this is probably more complicated to do. I think in US is even to some extent easier to have this kind of new combination. Actually, we certainly might expand this study, including carfilzomib, that is a new proteasome inhibitors. I think also the novel pomalidomide we hope to use from this point of view, and is needed, absolutely needed, to improve the treatment efficacy of the IMiD class of drugs.
But I think what's very important to remember is that obviously we have lenalidomide up front, we have pomalidomide, and what is so striking to me anyway in our experience with POM is that it's able to salvage lenalidomide failure. And I think what I like also about some of the second generation proteasome inhibitors is that they have the promise to be able to salvage first-generation proteasome inhibitor failure. And as I think the construct of, as we strive towards durable remission and better response that lasts longer, I think that's very laudable. But it's also nice that we have these sequences of therapies, because at the end of the day, in my practice, I see far too much relapsed refractory disease, and we need options for those patients.
So we need a strategy for the long term that incorporates a sort of continuous treatment paradigm, and exploring that's going to be really difficult. But you know, in conclusion, these are really exciting times for patients, really. I mean, the doctors that are involved, but it's the patients that are getting the benefit from it. So I'm really pleased for the patients. And so, you know, I'd like to thank you for coming, Paul and Antonio, and hopefully this was an interesting discussion, and thank you.